Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with our podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk with Dr. Ben Brody about Joint Commission surveys.
So we're very happy to have Dr. Ben Brody, who is the Service Chief for Acute Care Services in the Department of Psychiatry at Weill Cornell and New York Presbyterian Hospital, on bridging the gap between Joint Commission accreditation and high-quality behavioral healthcare reflections on a survey. So Dr. Brody, thanks so much for joining us today.
Thank you so much. It's really a pleasure.
Just to get us started, tell us a little bit about your career path and the current roles and settings that you work in.
Great. Yeah. So, my mother actually was a social worker on an inpatient psychiatric unit when I was a kid. So this was kind of my first exposure to a field, and it was talked about patients and things that were happening. So I was very aware of this kind of work. Fast forward, when I was finishing medical school, I did a sub-internship on the inpatient psychiatric services of Weill Cornell Medical Center. And I was really taken with just the breadth of frankly, human experience, people from literally all over the world, speaking different languages, having different kinds of problems. And I was really drawn to that work. And so, long story short, over the next 10 years, I had every single job a physician can have on that service, from junior resident, senior resident, junior attending, teaching attending, ultimately unit chief. I was the unit chief on that service for 6 years until the beginning of the pandemic. And at that point, the unit shut down and turned into a COVID floor. And I moved up to the Westchester Behavioral Health Center in White Plains, New York, which is the kind of flagship inpatient psychiatric hospital in the New York Presbyterian system. It's over 200 beds, freestanding psychiatric hospital. There was a lot of course, reorganization. People's lives were changing during the pandemic. And I said, you guys look like you could use some help. So I moved into a couple of different roles and ultimately into my present role, where I oversee 7 different units on 2 campuses, focusing on different patient populations and trying to best deliver care for patients experiencing mental illness and trying to help them towards their recovery.
What drew you specifically to inpatient work?
A couple of things. I mean, the teamwork aspect of it was a key piece. I did not want to spend my career only in one-on-one interactions with patients. The ability to reach patients that we can't reach in our office because they don't come to our office, frankly. The ability to treat conditions that we wouldn't be able to treat outside the hospital because it wouldn't be safe. The ability to really see improvements quickly in patients. So a lot of our work is very long-term, but when patients come to acute care services, they're acutely ill. And actually, a lot of our interventions work very well. Of course, not always as well as any of us would like, but many, many of our patients get better, and they get better quickly, and that was really rewarding. So, those were the biggest factors.
I think we'll probably end up discussing this to some extent, but I think that there's certainly a lot of voices out there, particularly people with lived experience, who either during the time of the hospitalization or in retrospect feel that it was traumatizing.
Yeah.
And so I'm just curious whether that, was something that also contributed to your interest or an appreciation of that, or how did that play in your mind?
Yeah, it's one of the bigger challenges we face because many of our patients have not chosen to come to the hospital. And we're very proud to treat all patients, whether they've been involuntarily committed, whether they come because, their spouse or their parent, or hopefully not the police, but unfortunately, sometimes the police have brought them in and say this person is dangerous. And to try to make that experience something that by the time they leave the hospital, they can take some sense of, okay, actually, this was helpful to me. Maybe it didn't go the way I would have liked, or maybe I wouldn't have chosen this or maybe I wouldn't have chosen this in this particular way, but hopefully something is now better or more stable in my life, and I can get whatever help I can need outside of the hospital. And that's a tension in inpatient psychiatry. I don't think there's any real way around that tension.
I think that makes sense.
So just kind of moving on to the topic of the paper, which is an open forum in the journal. I think that this is one of those topics that can elicit really strong opinions among
Absolutely.
providers. But just, assuming that there are some people listening who may not be quite as familiar with the Joint Commission and what it does, like what's a quick overview of what the Joint Commission is and how they operate and how they interact with inpatient psychiatric settings in particular?
So the Joint Commission is a not-for-profit organization that works very, very closely with CMS, or Center for Medicare and Medicaid Studies, to set basic standards for hospitals across the country, medical hospitals, surgical settings, and psychiatric hospitals, and some outpatient settings too, but I focused on the inpatient setting. They do research, they do a variety of different quality initiatives, and one of the biggest things they do is they accredit hospitals as being what I believe they refer to as having a deemed status. And what that means, as I understand it, is that if you are a healthcare organization, you want to participate in Medicaid and Medicare, accept those federal insurances, you have to meet basic qualifications and show that you are meeting those qualifications every 3 years in the process that they call accreditation. So every 3 years, this organization, the Joint Commission, will come to your facility and really do a 360-degree review of the care that you do to ensure that it meets their basic minimum standards. And that process was the process that I, have participated in various ways in, probably half a dozen times now, going back to when I started working on inpatient psychiatric units. And in the wake of the most recent accreditation process for the institution where I work, I reflected on that process and ultimately wrote this essay.
One of the things that I really appreciated about the essay was that it did identify some things that you think the Joint Commission does well. So, like, what are some of the things that you think the process is helpful for and is something that we should kind of hold on to and keep on doing?
Yeah, so there's a number of things that I think they do very well. Again, focusing on things that clinicians like myself are not going to have on our radar on a day-to-day basis. So again, like the physical environment. I don't have any expertise in furniture design. I don't know, what type of refrigerator, for example, might be on a hospital, psychiatric floor. But these are things that they look at very, very carefully. What type of locks we have. That is wonderful because as a clinician, like I have no expertise in anything like that. So that's really helpful. They do things like a number of years ago, they said, okay, we're going to focus on suicide assessment. And, this is the biggest issue we have in psychiatry in terms of mortality. So they've set standards around suicide assessment and they scale those across the country. And I think that's helpful. And, it does require people to evolve their practices and to standardize practices across the country in ways that I think are ultimately helpful.
How does the issue of best practice fit in?
Well, that's ultimately what I get into in this piece. And I think where they could actually take things a bit of a step further. So the things that tend to get me really excited as, someone who, oversees clinical practices on a number of different units are things that we know work and we demonstrably have excellent evidence that they work at scale. So, and the things that make a real difference in things like mortality. So for example, things like medication-assisted treatment for opiate use disorders. We know very well that if we're not using MAT for opiate use disorders, that our patients are much, much more likely to relapse. The relapse rate without MAT is almost 100%. And if we use MAT, we do far, far better. And we know that we cut mortality, both from opiate overdoses and also all-cause mortality in opiate use disorder patients. So I think, for example, the Joint Commission says, well, you should screen patients for opiate use disorders or substance use disorders writ large, rather. And I'm saying, well, what happens if patients screen positive? I think that they could actually take it a step further and say, well, we're going to mandate some follow-up questions that at least all patients have been offered some type of MAT, and patients have been given a naloxone rescue kit at the point of discharge, rather than just saying you should screen patients for a substance use disorder. So I think opportunities like that are where there is, a way to really scale interventions that we know work.
I really loved your opening for the essay where you're talking about an issue that came up in one of your surveys around an asthma inhaler. And, that can obviously be a crucial medication, but in this case, it really wasn't. And the surveyor was focusing in on this issue that didn't seem clinically very meaningful, but caused a lot of extra work to go back and find out like the details about like who had ordered what and when and where. So one thing that I wonder as you're talking about instilling some best practices is like, have you thought about how to do that without making it something that's going to turn into something that is kind of more rote? Like I assume that the intentions of that are like, okay, well, medication reconciliation are a key point where there are errors that can be life-threatening are made. And so we have to follow up on any medication reconciliation issues, which like it makes perfect sense. But then if it's applied like kind of not in a way that's clinically meaningful. So how do you find a balance between standards and making sure that it continues to be useful as they're implemented?
Yeah, well, I think you have to focus on the things again that are demonstrably going to make a difference in patient care. So medication reconciliation is important and should be done because we want to ensure that patients are receiving appropriate treatment for all the conditions that they have. And once that's done, then I think we have to leave it up to the individual practitioners. There's a very long tradition of, comparing healthcare to, the airline industry. And I think we want to have basic standards for airplanes. We want to have basic standards for what aircraft look like, but we don't want to tell the pilot exactly how they should fly the plane under all circumstances. And this was an example to me where the surveyor was essentially saying, okay, not just are we going to have basic standards in terms of making sure that the conditions are treated, but we're actually going to tell you how to practice medicine on a day-to-day basis. And it went beyond where it was helpful to improving care. And look, I think she was trying to do her job as well as she could. And for some particular reason, this really bothered her. And ultimately, we were able to sort it out and it went just fine.
So just to push it a little further, I think that our field now is, and in medicine in general, has been forced and needs to include, in some sense, the customer, the participant, the patient in decisions about what's important. And I would even wonder, should the Joint Commission, and I can argue myself against this, but should there be some review of what they're looking at based on, by different stakeholder groups? I mean, in other words, it's not just us or myself as a physician and you as a physician, but there's other participants that maybe feel they should have a voice. Anyway, so I'm curious whether that's just completely wacky or, I mean, I don't expect it to happen tomorrow.
I think I would frame it slightly differently in that I think our documentation, the processes should reflect that we're involving patients in the decisions for their care. So to be clear, using the example of MAT for opiate use disorders, we cannot force patients to, accept MAT, to accept one of those interventions, but we can show that we've engaged the patient in a process where we've offered and educated and had a real discussion about, well, why is it that we are suggesting this treatment? And if we're showing that we're engaging with patients in that process, then I think we've demonstrated that we're making our really our best effort to help patient care.
Yeah, thanks. I think it just challenges us to sort of ask ourselves the question, who gets to decide what's important or what is necessary? And I think that, and I'm not saying that it shouldn't be, to some extent, the experts on screws and nuts should clearly be like making some evaluation.
We're all agreed that none of the three of us should be doing anything with like furniture or bolts, or I don't know what your home improvement practices are like, but my power drill is just gathering dust. So we're all out of that business.
Yeah.
That's right.
I just like to ask myself those questions.
Yeah. I mean, they're excellent questions. I mean, more broadly speaking, I think we need more crosstalk between regulatory bodies, clinicians, and public health researchers who really do have deep expertise in the things that can help our patients and from a public health perspective, reduce mortality. Another example is access to lethal means when patients screen in for having suicidal thoughts. A number of years ago, we, as one of the national patient safety goals, the Joint Commission introduced mandates that we start screening our patients for suicide risk. But it gets a little bit, it really trails off after patients screen in. Okay, so someone screens in for suicide risk, they are suicidal. It really trails off at that point. And so what are the things that we know are actually helpful on a population basis in terms of reducing suicide risk? Well, a big one is reducing access to lethal means. In our country, of course, that means firearms. And so, we could ask patients, do you have access to lethal means? And then take it one step further. And, I'm sure people who are listening to this will say, well, of course, there are gag laws in some states. You're not allowed to ask patients about guns in some states. But in fact, one of the areas where there's broadest consensus about gun control in this country is around limiting access to people who are experiencing a mental health crisis. There's been some very good work around this. And, 40 states right now require patients who have been involuntarily admitted to a psychiatric hospital to be reported to the National Criminal Instant Background Check database, which can limit their access to firearms. And there's actually pretty good bipartisan support when you ask the question specifically about people who are experiencing a mental health crisis. If there's specific states that say, listen, we don't want you to ask about firearms, fine. So, local laws should supersede whatever a recommendation would be. If you want to do something different in a different state, that's perfectly fine. But for the 45 states that say we actually do want to screen our patients who are experiencing a mental health crisis for access to firearms, then I think we should actually take it a step further, because most suicide deaths in this country are from firearm deaths. So we're not really taking suicide prevention seriously if we're not talking about access to lethal means. In New York, that actually may be somewhat different. So we have fewer firearms in New York City, but we have lots and lots of tall buildings. So access to lethal means also means asking about things like window guards. It means asking about things like, stashes of medication that patients may overdose on. But I could easily imagine a circumstance where if patients screen in for suicidal thoughts, the next question is, well, do you have access to lethal means? And if so, what has the clinical team done to try to make an effort to limit that access to lethal means? Because again, we have to own the things that we know, that we actually know to be true in our field. One of the things that we know is that many patients who are suicidal, if you get them through an acute crisis, will not, and you do limit their access to lethal means, they will not go and try something else. That's been, pretty well documented. So I think that these are the kinds of things that we could scale by focusing on the things that do make a difference and removing some of the things like comprehensive treatment plans, which I hope we get a little bit of a chance to talk about, which we know, frankly, don't make a difference and are really are just an administrative burden.
Go ahead and get comprehensive treatment plans off your chest.
Yeah, so as I've said, one of the things that the Joint Commission does is look very seriously at documentation. Comprehensive treatment plans are a document that is a legacy document that I think comes out of the 1960s or 1970s when lots of patients were frankly warehoused in state psychiatric institutions without any particular treatment or treatment plan. And so at that point, it made sense for patients to have a specific treatment plan. Anybody who trains in healthcare knows that different disciplines, whether you're a physician, a social worker, a psychologist, a nurse, you do your assessment and you write a note based on your assessment. And so a treatment plan document is an extra document after you've done your assessment as a nurse, for example, and our colleague from social work has done their assessment, and I've done my assessment as a psychiatrist. We've all written our individual notes. Now we all have to write an extra note at the end that we all sign that is going to probably say a lot of the same things that our individual notes said. And that's there's no other area in healthcare that requires this. In 2020, the American Psychiatric Association issued a position statement saying that these documents are an unnecessary burden. And in this piece, that's the first thing that I cite as a burden that could be eliminated. And the final thing that I cite is the CEO of the Joint Commission in a blog post saying that they're looking to eliminate overly burdensome requirements that don't add value to patient care. And so I really kind of bookended the piece with the APA position statement and the CEO of the Joint Commission saying we're actually looking to reduce requirements that are frankly not helpful.
So do you think that just the whole paradigm makes sense of like a surveying body that's coming in, talking to people, doing chart reviews? Like, would you, if you were the CEO or you had the magic wand, would you keep that and reform it? Would you try something else differently entirely? Like, what would your ideal state here be?
Yeah, I would absolutely not get rid of the Joint Commission any more than I would get rid of the FAA to inspect planes and say that a particular type of design for an aircraft is safe, or that an aircraft that's been in service for 10, 15, 20, sometimes longer years is still safe to fly. So I think that they have a really hard job, and I think that they're critical for ensuring that our healthcare services are safe. I also, I have to acknowledge, I mean, I work for an institution that, relatively speaking, has a lot of resources. And there's lots of community hospitals, hospitals in more rural settings, et cetera, that don't have as many resources as the institution that I work for. And they probably need more guidance in terms of basic standards. So I would absolutely not get rid of the accreditation process. But I do think that it really should be reformed and improved in such a way to reduce wasteful requirements like the treatment plans and to really go a step further in the things that we know make a difference to patients, like MAT for opiate use disorders, for example, or access to lethal means in patients who are experiencing suicidal thoughts or at risk for suicide. So I would focus more tightly on the things that we know make a difference, we know are scalable, and that we know reduce mortality. That's really what I see the opportunity.
Okay, I have one other question, but before we get to that, anything else that you wanted to make sure that we highlighted?
One of the things that I would emphasize is that it's very hard to get individual clinicians to change their practice. And we know that practice standards have to evolve. And the things that the Joint Commission emphasized are the clearest way to get lots and lots of clinicians across the country to change their practices and adopt practices that we know are going to make a difference in patients' lives. I think it's critical that the things the Joint Commission focuses on emphasizing in terms of their survey process are things that we know are going to make a difference in patients' lives.
So I think that leads into my final question as well. As so you're overseeing these inpatient units. So I'm sure you're doing quality improvement projects outside of what the Joint Commission survey is. And I'm just wondering if you have an experience or a vision for quality improvement that really engages the stakeholders, whether it be the psychiatrist, the social worker, the nurse, the security guards, so that you could get to something where the Joint Commission visit was something that people maybe looking forward to, might be a little bit too
Sure.
idealistic, but
Yeah.
would be something where people say like, oh, this is actually an opportunity for us to make sure we're delivering the type of care that we want to be delivering, that like we're providing excellent care and we get to show people that as well.
Absolutely. The biggest piece of it is to listen to what our individual clinicians who are working with patients all the time are telling us about the system, what the EMR emphasizes, what it gets right, what it gets wrong. One of the things that we did with nurses recently is that we moved to an electronic system to conduct checks. So in inpatient psychiatric units, most patients are checked every 15 minutes just to make sure that they're safe. And inevitably, errors can be made. And for years, that process was done by hand, but we did recently move to a system where that is being done with an iPad. And if someone has not been checked within 15 minutes and noted to have been checked, there's kind of alerts that come in and say, okay, this person needs to be checked on. So I think using technology is going to be one of the ways that we really can improve quality. I have, a psychiatrist who works on our psychosis service who has helped with our EMR to improve the medication reconciliation process at discharge, because any of us who have discharged patients from hospitals know that sometimes there's a bit of a rush at the end. And well, you might have adjusted a dose or you might have sent prescriptions a couple of days ago, but there may be a small change in the medications between when they were sent on, Monday morning and Thursday when the patient was finally discharged, and some of those errors were getting missed. He came up with a way to improve that process such that the medication reconciliation was being kept up to date. So it's listening to our clinicians and hearing the kinds of experiences they're having that we can then take back and scale across our institutions and ultimately our healthcare systems. And I think, one of the things that I would close on is that I think there's going to be a tremendous amount of opportunity over the course of the next, 5, 10 years to really harness tools in the electronic medical records to really, really improve quality. So that when a patient has been admitted to the hospital and we are, using tools that can look at the medications patients have received and say, okay, this patient has failed 2 antidepressants or, 2 antipsychotics. And so, maybe we should be thinking about ketamine or ECT for this patient with depression, or this patient who has psychosis who's been admitted 4 times really should have a clozapine trial at this point. And I think we're going to be seeing AI tools that can look at the individual health records and start to come up with those kinds of suggestions. And I think that's going to be the biggest way to really push quality over the course of the next couple of years and ultimately next decade, because we don't take advantage of what we know about patients. We don't have enough access to what's actually in our EMRs in ways that can scale it. Right now, if I see somebody, in my outpatient practice, I might get a notification saying, your patient's overdue for a mammogram. And I might, I may or may not say, hey, by the way, you're overdue for a mammogram. But it might actually affect the way I think about that patient. It might actually say, I wonder if this patient is not actually paying as close attention to her health as she should be. And I may act on that information in a number of ways, depending on the context and the type of work I'm doing. But I think that's going to be the kind of thing we can really, really improve over the coming years by saying, okay, this patient has never had a lithium trial and their creatinine is perfectly fine. and they've had suicide attempts, and they've had a diagnosis of bipolar disorder charted for over a decade. So why is that?
So can I just jump in for a sec?
Yeah.
And I think that how you're articulating this is so powerful in terms of how it can really improve care. And as you were saying, adopting or enacting the things that we know. I do want to put in another plug
Yeah.
for the participant or the patient having a role in this. And so, is shared decision making happening? Are the individuals being served? Not just are they getting, what can we see that they're getting or not, but also are the processes that include people in these decisions also being monitored?
I think it's an excellent point. And again, I'm not saying that the hard outcome should be that the patient leaves on clozapine or the patient leaves on, buprenorphine, or that the patient leaves on lithium. I think that the hard outcome should be a demonstration that you've had that conversation, that shared decision-making interaction with patients, and that it's happened. Because if we're not talking about these kinds of things with patients, offering them to patients, then I don't think we're doing our job as acute care providers in hospital settings. We only get to spend a little bit of time with patients in hospitals, hopefully, and we need to make the most of that time.
Agree. And I also wanted to say one last thing, which is I'm sure your mother's very proud of you.
Most of the time. Appreciate that. Still enjoy that.
Well, we'll end that note, a mother's pride and AI coming in and helping us to improve care. Very future oriented and interesting. It's like it's also an interesting question is like, how would you use an AI tool to make sure that a meaningful shared decision making conversation is happening? What else would need to go? What other data would need to be in the chart in order to do that, or not in the chart? So we'll end there, and we'll have you back to talk more about it in a couple of years.
Well, thank you very, very much. I really appreciate it. I've enjoyed the podcast in the past, so it's really a special treat to be a guest.
That's it for today. Thanks to Aaron Van Dorn for mixing and editing, and Demery Jackson for additional production support. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk with you next time.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.